Our final speaker of this session, which is Dr. Mai-Lei Kinshella, who's from King's College London, who's going to talk about a conceptual framework of the clinical and social determinants of preeclampsia. So again, another study looking at something wider than just hypertension and proteinuria, which I grew up with as a study area for preeclampsia, and it's demonstrating the importance of looking at a bigger sort of area of data collection. Thank you very much.
Thank you very much for a warm welcome and a really interesting presentation so far. So I'm glad to be a part of it. I'm just going to share my slides. Okay, can everyone see this? Okay, wonderful. Thank you. So thank you again for welcoming me here. I'm presenting on behalf of the Precise Network, and this has been an accumulation of a number of years of work, which is led overall by Prof. Von Dadelson, as well as a whole consortium of really amazing researchers and clinicians and advocates from all around the world. So I don't think I have to talk too much about the background of preeclampsia here, but just really briefly that preeclampsia is a leading cause of preventable maternal and newborn deaths worldwide. It's associated with over 46,000 maternal and 500,000 perinatal deaths annually. And there's growing evidence that it's a very complex condition. I think we heard that in the previous presentation in the POPPY study about how there can be so many different factors leading into this condition, and then the condition itself is quite complex. And there's growing awareness that there are clinical and also social risk factors. So clinical as well as some of the non-medical factors that can increase the risk of developing preeclampsia. However, one of the challenges is that there's a lot of literature and it's spread across a very vast literature base, and that it's often very siloed, that the clinical factors you might see in one literature set, whereas the social factors are seen in a different literature set. So our objective coming into this was to create an integrated conceptual framework of the strongest social and clinical determinants of preeclampsia. And the aim of this was to better understand the pathways of risk and identify potentially some actionable prevention points. So just to give a broad overview of our methods, it was a comprehensive evidence synthesis, particularly we were looking for reviews and large cohort studies. And our explicit aim of this integrated conceptual framework was to include both the clinical and social determinants. And then we also utilized grade to assess the quality of evidence, as well as we assess the strength of the association as definite, probable, possible, or unlikely. So first we did individual clinical and social frameworks, and this way we could really dive into each of the areas and make sure that we have had a comprehensive search. And we use a hierarchical approach. So we did a systematic search, and then we went through and prioritized the evidence from umbrella reviews and systematic reviews with meta-analyses, RCTs, and then lastly, individual cohort studies if no reviews were available. Then we assessed using the quality of associations and the strength. And then what I'm presenting here is the combined framework. And so we combined the strongest factors, and then we also looked for indirect associations. And just a little bit of background. So we are the Precise Network, which is a multi-country research network with a flagship project of a prospective cohort study in the Gambia, Kenya, and Mozambique. And the idea was to investigate placental disorders, particularly preeclampsia, preterm birth, fetal growth restriction, and stillbirth, and particularly looking at if there are any differences in pathways in resource-limited settings. And as a consortium, we undertook the development of this comprehensive conceptual framework for preeclampsia to understand the evidence and to inform analyses. And then this whole process was informed by patient and community partners, both in the UK and globally and Canada, but also with partners in each of these countries. So going back to the integrated framework, which I'm talking about today, so we combined the strong associations from the individual reviews on clinical and social factors. So when I mean strong, this meant that it had at least a probable strength of association of a risk ratio and odds ratio of at least 1.5 or 0.68. And then it graded it was assessed on grade as at least a moderate quality of evidence. And then we took those strong associations from those individual reviews that we're looking at direct associations between a risk factor and preeclampsia. And then we also wanted to look at the pathways. So we tried to look at if there were any indirect associations between those risk factors. So we were looking at strong clinical to clinical factors, social to social factors, and clinical to social factors. And then we also wanted to highlight modifiability, which we defined as any determinant that could be modified through interventions at either an individual or population level. So this could include altering social norms, personal behaviors, or clinical pathways. So our key findings was that we found 35 strong determinants of preeclampsia, including 14 clinical factors, 10 social factors, and 11 indirect factors. And many of these were modifiable, so 31 of them were modifiable. And then we illustrated these in a map here. So as you can see here, this is kind of our conceptual framework for preeclampsia prevention. And note that these are just of what we had classified as a strong association. So these are all based on definite or probable associations that graded a high or moderate quality of evidence. So on the left of the screen here, you can see the clinical determinants. And it's quite interesting because I feel like this really speaks to some of the evidence that has been in the literature, but also to the Poppy presentation, the study in the Poppy presentation that came before mine. And the strongest evidence that we saw was around a high BMI, but also interlinked with chronic hypertension or elevated blood pressure in early pregnancy, as well as type 2 diabetes and obstructive sleep and apnea. Other factors other modifiable factors that emerge with strong evidence was smoking, phospholipid syndrome, as well as infection. And then some non-modifiable factors, at least in the index pregnancy, is prior stillbirth, prior preeclampsia, prior history of preeclampsia in the mother or sister. So, and also fetal trisomy 13. So overall, these kind of links illustrate overlapping cardiovascular pathways. And then on the social determinants, what we find was that the key modifiable factor was antenatal attendance interlinked with maternal and work stress, as well as prenatal micronutrient supplementation. And these really highlight how healthcare access and stress influences maternal outcomes. We also, though we didn't see a direct link, um, other parts of healthcare access included distance to the health facility. Looking at the cross quadrant, cross kind of clinical social interactions, we didn't find any strong associations, but we did find some possible pathways that link social stressors and clinical risk, including work stress to type 2 diabetes, higher BMI, smoking and pregnancy, as well as UVB exposure and lower hypertension, smoking and fewer antenatal care visits, overweight, and late antenatal booking. So this really suggests a multifactorial nature of preeclampsia development, but also gaps in current evidence. So this kind of highlights that we can do more. So in summary, this conceptual framework pioneers integrated synthesis of 35 social and clinical determinants of preeclampsia based on systematically graded evidence. And it really emphasizes that there's these interconnections between the metabolic, cardiovascular, environmental, and healthcare pathways. And we really tried to provide a visual map of putting all this evidence in one image. And what the implications for care and policy is that there were many that were potentially modifiable, though modifiable at different levels. So there is some areas where it can be clinically modifiable. Managing hypertension, diabetes, and infection, particularly like promoting tight control and preventive care could be a way it supports these clinical approaches, but also that we need to complement it with system level um, public health strategies to strengthen antenatal care services as well as occupational protection and address social and work stress and barriers. So some of our next steps is that this framework informs research, particularly within our PRECISE network, but also can hopefully inform research more broadly. We've been in discussions with some patient partner and advocacy groups in how we could utilize this research to develop some patient-centered clinical discussion tools. And then also this research helps to support advocacy to improve health systems strengthening. So I know for time, in conclusion, that this framework underscores that preeclampsia risk is not only biological, it's really shaped by women's lives, embedded in their communities, and their health systems. And it integrates the clinical and social determinants to offer potential pathways for prevention and advocacy and overall, hopefully, improved maternal and child health outcomes. So a huge thank you to all of our funders, as well as our patient partners of who this project wouldn't have been possible, and all of our network and institutional support. So I'll end there. Thank you.
Thank you very much. And there are no questions in the question answer so far, but I'll chip in. The presentation you've just given, along with the poppy study before that, and also links very nicely into what Professor Khalil was talking about as well, because you've got all these areas in which you're highlighting the fact that we lack information almost, that even though we've got theory, we lack the linkage, we lack what is going on. So we've got lots of questions which could be developed into good research and then presented with the help of advocates like Professor Khalil to actually try and get funding for. So, when looking at all this, have you got any specific areas which you'd want to sort of first of all look at and manage our research?
Oh, so what are the target areas that we should look at?
Yeah.
Well, speaking from my own personal experience, I'm sure that others in the network have their own areas that they're very interested in. Is I would like to see some more of these cross social to clinical indirect pathways. And I think that so the research in Precise, the research that I was that it seems like coming out of Poppy as well, that we're starting to collect this data within cohorts, and we're going to be able to link some of these things because I think that intuitively, maybe we have these research questions that we kind of understand that um, there are social determinants to clinical risk factors. And indeed, we've seen it in um, potentially other areas. But sometimes because of the nature of how social research is conducted, it doesn't always link to, it's not always linkable um, to clinical risk factors. And then that's where I feel like some of the research we kind of know it's there, but it doesn't always come up when we're doing these evidence synthesis. And I believe that through our patient partners, when we were talking to them, this is actually where people are quite interested in. So I think that this is a very important area of future research, as well as thinking about some of these interconnected pathways that are emerging.
So do you feel that what's required is greater width of study by having larger numbers, looking at different populations and countries, or greater depth by taking specific areas and looking deeper into the associations of them and clinical factors?
Well, ideal world would be having both of those. But I think that it would be important to first kind of get this broad view and then be able to narrow it down in the future.
Okay. Well, thank you very much. I'm going to get shouted at by Marcus because I've run my time badly, very badly managed chairing. So.